in the literature that definitely suggests that there is a certain measurement that is clinically important, although there have been some studies that have suggested that a 3 millimeter difference between legs might be important in runners, and that for low back pain, a 5 to 9 millimeter difference might be important. So it's been suggested that leg length inequality might be associated with a number of different orthopedic conditions. This includes low back pain, scoliosis, osteoarthritis in the lower body, iliotibial band syndrome, knee and ankle injuries, foot pathologies, and stress fractures. And a lot of what's been published in the past has looked mostly at patient samples. There was a cohort study, the MOST study, the multi-center osteoarthritis study, that did look at greater trochanteric pain syndrome. So this was any tenderness on the greater trochanter to palpation. And in that large cohort study, they did not see an association between leg length inequality and greater trochanteric pain. So most of what I'll focus on today is my research looking at leg length inequality and knee and hip osteoarthritis. And the first couple of studies that I will talk about are listed here on this slide. And they were cross-sectional analyses of a large cohort study. So the Johnston County Osteoarthritis Project was the cohort study that I worked with. Joanne Jordan is the principal investigator of this study. And Johnston County is a mostly rural county in North Carolina that's shown in red on this picture of North Carolina. It's just southeast of Raleigh. And the Johnston County Osteoarthritis Project is the population-based study that includes participants that are 45 years of age and older, who are African Americans and Caucasians. And when the study began in the early 1990s, it had 3,000 participants. And what I'll be talking about today will be data from the 3,000 participants enrolled during the 1990s, and then data from the first follow-up. So in the Johnston County Osteoarthritis Project, limb length was measured using a tape measure from the anterior superior iliac spine to the medial malleolus. And there are a number of concerns about potential sources of error with this measurement. Some of it may be difficulty in finding bony landmarks. And also, we tend not to be symmetrical, so sometimes the shape of a bone on one side might be slightly different than the shape on the other, and that may affect where we end up putting a tape measure with doing this measurement. And also with this measurement, it doesn't include the feet, and the feet might contribute to an overall leg length difference. So for this study, we decided to use a conservative definition for leg length inequality, saying that there needed to be at least a 2 centimeter difference between limbs. And then for the study, we looked at radiographic knee and hip osteoarthritis. So based on X-ray, Kellgren-Lawrence grades were done, and we defined anybody having OA as having at least a Kellgren-Lawrence grade of 2. And then in the Johnston County study, questions were asked about symptoms. So participants were asked on most days, do you have pain, aching, or stiffness in your left or right knee or hip? And about presence of symptoms in the groin, which was used to help define hip symptoms. And then we also asked about severity of joint symptoms, so whether they had pain, aching, or stiffness that was mild, moderate, or severe. So you'll see that in the Johnston County study that radiographic knee and hip osteoarthritis are common, with 29 and 25% of the participants having radiographic OA at the knee and the hip. And then knee and hip symptoms are also quite common, with 44% and 41%. And then using the conservative definition of a leg length inequality of at least 2 centimeters based on the tape measurement, nearly 7% of participants had a leg length inequality. And so these are the results of our cross-sectional associations. So what you'll see here is that we had an 80% greater odds of knee osteoarthritis for those with a leg length inequality than compared to those who did not. We did not have a statistically significant association for the hip, although we do see that there's an association. And the results that I'm presenting here were adjusted for gender, race, age, and history of knee or hip joint problems. So that includes any injuries or surgeries that they might have had, and also controlling for body mass index. And in this next slide, we're looking at symptoms. And again, we see a similar pattern to what we saw on the prior slide for radiographic osteoarthritis, where there is a statistically significant association between leg length inequality and knee symptoms. And the association is not statistically significant for the hip, although we do still see that there's a relationship. So the other thing that we were interested in seeing is if there was a relationship between leg length inequality and symptom severity. So in this slide, what we have done is we're showing the by joint whether participants were reporting having no symptoms, mild symptoms, or moderate to severe symptoms. And then we were looking at how common they were reporting these symptoms by whether they had a leg length inequality or they did not have a leg length inequality. And what we see is that what I've highlighted in red is that we did see some differences with the moderate to severe symptoms, where for both the knee and the hip, those who had a leg length inequality were more likely to report moderate to severe symptoms than those who did not have a leg length inequality. These results weren't statistically significant, but I still think it's interesting to see the difference. So as I mentioned, one of the limitations of this study was the tape measurement of leg length inequality, and we tend to think that radiographs might be more reliable, perhaps a better way to measure a leg length inequality. And so what was nice was that actually another group did a similar study to what we did. And it's the multi-center osteoarthritis study. And what they did was they had full-length X-rays of the legs, and so they were able to look at the relationship between leg length inequality and knee osteoarthritis. So the MOST study is a prospective cohort study with subjects that were recruited from Birmingham, Alabama and Iowa City, Iowa, and it included about 3,000 participants who were 50 to 79 years of age and who were at high risk for having knee osteoarthritis or they already had osteoarthritis. And the purpose of this study was to look at leg length inequality and its associations with prevalent, incident, and progressive knee osteoarthritis. And subjects in this study were reassessed at the 30-month follow-up. So here is an image showing what they measured for their standing full limb radiographs. They measured from the center of the femoral head down to the base of the tibia. And then in this study, they had two different definitions of leg length inequality. They had a 1 centimeter difference based on radiograph and a 2 centimeter difference. And for the 1 centimeter difference, 14.5% of the participants had a leg length inequality. And for the 2 centimeter difference on radiograph, 0.9% had a leg length inequality. So what I have done here, these are some crude comparisons looking at the Johnston County Osteoarthritis Study results versus the results from the MOST study. And this is for looking at the relationship between knee osteoarthritis and leg length inequality. So on the left-hand side, the 2-centimeter tape measure is the result from the Johnston County Osteoarthritis Study, and then the 1-centimeter radiograph and 2-centimeter radiograph definitions for leg length inequality were from the MOST study. And what you can see here, again, these are unadjusted analyses, so not controlling for any other variables, because the other studies, the two studies did not control for the same variables. But just looking at the crude relationships, we do see that there is an association between knee osteoarthritis and leg length inequality based on these different definitions of leg length inequality. So the previous studies and results that I presented were from cross-sectional analyses. And one of the things that we wanted to be able to tease out was whether the leg length inequality preceded knee osteoarthritis and hip osteoarthritis. So in 2010, we published a study looking at our longitudinal data, so looking at the data from Johnston County that were collected during the 1990s at baseline, and then data that were collected during the first follow-up visit to see if there were incident or progressive knee and hip radiographic osteoarthritis or joint symptoms that differed by baseline leg length inequality. And these are the results of the Johnston County study, and what I presented here are adjusted hazard ratios. So we had on average 6 years of follow-up time. So we think that some of our results aren't very strong because it might not have been a long enough period of time for people to go on to develop radiographic knee or hip osteoarthritis or new symptoms in their knees or hips. But what we did find interesting was this relationship that I've circled here in orange, showing the progression of knee osteoarthritis and how that's related to leg length inequality. So we found that those individuals that had an inequality at baseline, based on tape measurement and the 2-centimeter definition, they were more likely to have rapid progression of their knee osteoarthritis compared to those who did not have a leg length inequality. And so this is a comparison of the MOST study and the Johnston County Osteoarthritis study. And what you'll see here is that the 2-centimeter tape measure is on the left, is the result for the Johnston County Osteoarthritis study, and then the two results on the right are from the MOST study looking at radiographic definition of leg length inequality. And we see that there does seem to be this relationship between leg length inequality and progression of knee osteoarthritis. For the MOST study, they did not have as long of a follow-up period as the Johnston County study did. Johnston County, we had 6 years of follow-up data. The MOST study had 30 months of follow-up data. So it would be interesting to see in future analyses where more data have been collected, whether we continue to see this relationship when you do have more follow-up time. So I often wonder whether osteoarthritis occurs more often in the longer or the shorter limb. I think at this point we're not entirely sure, although when you go to the literature and look at some of the studies that are based on patient populations, some studies will say that back pain or sciatic pain and hip symptoms and hip osteoarthritis may occur more often in the longer lower extremity. Other clinical studies will say it's the shorter. So I have looked a little bit at the results from Johnston County as well as the results from the MOST study. And it seems as though there might be something for the shorter limb when looking at the Johnston County osteoarthritis study and looking at hip osteoarthritis. Although we've only seen these results so far in just the right limb. We didn't see it in the left limb. And the results that we had, we did not see any relationship by shorter versus longer limb for the knee. The MOST study, they looked by limbs, and they did see that prevalent radiographic knee osteoarthritis was more common in the shorter limb, as well as symptomatic knee osteoarthritis. They found that incident symptomatic knee osteoarthritis was common in the shorter limb and the longer limb, so there wasn't really a bi-limb difference there. And then their significant results were for progressive knee osteoarthritis in the shorter limb. So at this point, what we know is that leg length inequality is associated with knee and hip osteoarthritis, knee and hip symptoms, and progression of knee osteoarthritis. But we still have a lot more questions about this relationship, and so the next steps that I'm involved in are looking at this relationship of leg length inequality and osteoarthritis over a longer follow-up time, which we now have with the Johnston County osteoarthritis study. There have been 2 other follow-ups visits that have occurred or are in process that allow us to look at this. And then we're also in the process right now of doing an intervention study where we are trying a shoe lift intervention in people who have knee and hip osteoarthritis and a leg length inequality. So I'll talk a little bit more about this work. So this is actually a part of the K Award that I'm doing, and it's looking at some of our participants in the Johnston County osteoarthritis study who have a leg length inequality. And the first aim of this study is we wanted to look at all of these different clinical measures for assessing leg length inequality and see how they compared to that gold standard of the X-ray. So for this study, we did a standing X-ray, and then we're doing a number of different comparisons with tape measure compared to X-ray, as well as a standing block method compared to X-ray. And then I'm also looking at how the foot relates to leg length inequality, because there's this idea that perhaps a foot with a higher arch, a person who has one arch that's higher than the other, that might contribute to leg length inequality. So we have some data that we're looking at for that relationship. And then the other part is looking at the shoe lift intervention as a way to help people who have knee and hip osteoarthritis and a leg length inequality. So I would like to thank all of the support that I've had on the project that we've done with Johnston County, and my own support for looking at leg length inequality and its relationship to osteoarthritis. And then I have a number of collaborators and my study team who's helped me out quite a bit with my work over the past few years looking at leg length inequality. And thank you very much, and I welcome questions.
Thank you, Dr. Golightly. That was very interesting, and I think we'll look forward to some continued follow-up to see how all of this develops over time.